Good day, everyone. I hope everybody's okay and safe wherever you are in these challenging times of the COVID 19 pandemic. My name is Dr. Winston Palasi from the Disease Prevention and Control Bureau, and I'm glad to be part of this meeting. But before we start, first, I would like to thank Vitamin Angels for inviting me in this meeting and the opportunity to talk about this topic. So, this day or today, I will be discussing about the status of soil transmitted helminthiasis and the MDA coverage in the Philippines. So, the objective or the outline of my presentation goes this way. First, I would like to describe the situation of soil transmitted helminthiasis in the Philippines. Second, I would be describing the program goals and strategies and the control of STH. Third, I would like to discuss the challenges and issues in program implementation during the COVID 19 pandemic. Fourth, I would like to discuss the summary of program initiatives and accomplishments to address issues and challenges as a result of the COVID 19 pandemic. And finally, will be a discussion on the program next steps and way forward. This slide will show you the burden of soil transmitted helminthiasis in the Philippines. I would like to emphasize that there are two important outcome indicators in the control of STH, namely the cumulative prevalence and the prevalence of heavy intensity infection. As you can see in this slide, prevalence studies conducted for the past 10 years had shown a decrease in the cumulative prevalence among the different at-risk groups, particularly for preschool age children and school age children. And recent reports from the RITM have showed a cumulative prevalence of 22.6 among preschool and 28.4 among school age children. However, among at-risk groups or the groups belonging to the women of childbearing age, there's a need of follow-up surveys, such as adolescent females and pregnant women, since the earliest data available was recorded in 2011. But it also shows that the baseline prevalence was way above the threshold set by WHO for both cumulative prevalence and heavy intensity infection. I would like also to show you the national parasite prevalence study that was done among school-age children in 2015. Here, you will observe that the overall prevalence was 28.4%, and it could be seen that Region 5 had the highest stage cumulative prevalence, while Region CAR had the lowest. Region 4B had the highest prevalence of heavy intensity infection, while CAR registered zero prevalence of heavy intensity. You will observe also in the right side of this slide the top 11 provinces, which are either belonging to the regions who are ranked number 1 and 2. And it's actually highlighted in the map in red color. So using the survey that was done in 2015, then we can come up with stratification of classification of the different provinces. And this is very important because this will later on dictate or tell us what would be the modality or frequency of preventive chemotherapy. So the program is currently with talks or discussion with partners, And there is a recommendation by the WHO that for those cumulative prevalence of less than 1%, then we will be stopping mass drug administration or deworming. While those with a prevalence of more than 1 but less than 10, we can do a twice a year or twice every 2 years rather campaign, while for those with more than 10 but less than 20 will be once a year MDA, while those for more than 20 but less than 50 will have to maintain the twice a year frequency, while for those more than 50% we have to increase it to three times a year. But this recommendation is not yet final because it's still being discussed or still on progress with partners. So aside from those identified earlier as at-risk population, indigenous peoples or cultural communities are as well affected or as well at risk to STH infection. And you can see that there are special studies done in selected provinces in Davao del Norte as well as in Agusan del Norte, showing a high cumulative prevalence of 34% and 45% respectively. This is way above the threshold of less than 20%. Fresher data also suggest or show that the prevalence and intensity is still high, no? And you can see in this slide studies done in the municipalities of Pampanga as well as in Davao del Norte in 2018. And both indicators showed way above the WHO threshold of less than 20% cumulative prevalence and less than 1% heavy intensity infection. Just to note that military and paramilitary personnel are at risk as well to STH infection. And this is a special study that was done in 2004, showed a high STH prevalence and particularly hookworm species was also registered as high as 46.9%. So to address the STH burden in the Philippines, what is the Department of Health and partners doing to control this parasite? So the program that is in charge is, we call it the Integrated Helmet Control Program. And it is an integrated approach because it involves other important interventions to prevent the transmission of STH aside from providing mass drug administration or deworming services. And this integrated health men control program is embodied in the strategic plan that was crafted 3 years ago for the control of HTH infection in the Philippines. So, what is now the goal of HTH control in the Philippines? It's actually elimination of STH as a public health problem in the Philippines. So we define elimination as of STH as a public health problem when there is a reduction of prevalence of moderate to heavy intensity infection in children. This is among preschools and school age children to less than 1%, and a reduction of cumulative prevalence to less than 20% in children. So the plan also included emphasis on the design and implementation of an integrated package of interventions that is coming out with set of interventions strategically, meaning focusing on areas with high prevalence but with low wash coverage, and also expansion of the packages of state services and interventions to other vulnerable groups like pregnant women, women of childbearing age, indigenous communities, and other vulnerable groups, because the current intervention is still selective treatment, but we want that we will also be implementing preventive chemotherapy through mass drug administration. The plan also contained a continuing technical assistance to national partners like the Department of Education, who is implementing the school-based MDA, as well as to the local government units. So, with technical guidance from the WHO, the strategy is actually combining or including several strategic interventions, namely preventive chemotherapy, that is the mass drug administration campaign or deworming, wash or the water, sanitation and hygiene. It includes also vector control for the other entities and veterinary public health, as well as intensified case management as an integrated approach. And following that recommendation for WHO and specifically for the integrated helmet control program, came up with different in this framework for IHCP strategies and activities. And this framework is just showing you that doing more has a greater health impact as compared to a standalone or individual interventions which is resulting to lesser impact. In short, the ideal would be an strategic interventions that would be combining deworming, hygiene education, safe water, and basic sanitation. So as far as mass drug administration concerned, the program came out with this strategy so-called harmonized schedule and combined mass drug administration wherein both the community-based and school-based deworming is done simultaneously. You can see in this slide that for the community-based deworming is targeting preschool age children that is aged 1 to 4 years old, as well as school age children that are ages 5 to 19 that are out of school and those in private schools. While for school-based deworming, it is more focused on the public schools, targeting age group 5 to 12 as well as 13 to 19 years old. Also, the harmonized schedule combined mass drug administration involves or integrates the other NTDs like schistosomiasis and lymphatic filariasis. So, for the January campaign, both we are administering or distributing drugs for STH and schistosomiasis, and for the July is for STH and lymphatic filariasis. Let me now go to the different challenges and issues in program implementation during the COVID-19 pandemic. You can see here the different issues. So number one that have been happening is that there had been cancellation of the implementation of program activities, including intra and interagency consultation and coordination due to the COVID-19 pandemic at different levels. There had also been delayed delivery of MDA drugs and logistics to DOH and delayed distribution to different cities, provinces, and down to the LGU service delivery points, as well as the DepEd implementing units, which are the schools. It also resulted in the overstocking of supplies in some cities and LGUs because of the non-distribution to lower implementing units and service delivery points. This was compounded by the suspension of DepEd activities and face-to-face classes. Program implementation for NDA services either were delayed or stopped due to imposition of quarantine procedures and granular lockdowns. This was aggravated by the occurrence of disasters and calamities in selected CHDs and LGUs, as well as in LGU implementing units, as well as delayed transfer of also of drugs to DepEd from DepEd schools to LGU facilities, and funds and resources that is intended for the program operations were either realigned or reprogrammed for COVID-19 response. Continuing challenges as well is the increasing the MD coverage to 85%, which is have not been met. Aside from that, aside from COVID-19 response, low coverage was also associated with the prioritization of other public health programs like the recently conducted polio campaign. Well, there is also insufficient program capacity on monitoring and evaluation of impact of deworming and assessing progress whether program objectives are met and targets achieved. And there is a limited progress of implementation of interventions in the other at-risk population like women of childbearing age, pregnant women, and occupational groups. It's a continuing challenge also that there's also an so-called low MDA compliance and MDA fatigue, as well as the lack of ownership of MDA program by some local government units. And lastly, there's a slow progress in the integration of water, sanitation, hygiene as an integral part of control of STH. So, what has been the program initiatives and accomplishment to address issues and challenges as a consequence of the COVID-19 pandemic? Well, the Department of Health have issued several issuances. Number one would be issuance that essential provision of health services should continue amidst the pandemic. And in the course of the implementation of these essential health services, minimum public health standards should be observed. The program also issued several guidelines. So, number one, we have issued the interim guidelines for integrated helmet control as well as for schistosomiasis during the COVID-19 pandemic, wherein there's postponement of the MDA or deworming campaigns as well as surveys and active case finding. However, selective interventions should be continued that would address morbid conditions as well as the control of vectors and vector control measures. Routine deworming of children 1 to 8 shall be community-based rather than school-based, and this should be integrated alongside with other child health and nutrition services or interventions. And partners are enjoined to follow the WASH strategy, like hand washing, use of sanitary toilet, and hygiene promotion and related interventions as part of the interventions to curb the COVID-19 pandemic, and use of other existing entity platforms to support implementation of COVID-19 measures. The program also issued a specific guideline on the routine delivery of deworming services. And as mentioned to you a while ago, the implementation now of the mass drug administration 6 months interval or biannual should be on an individual approach at the community level. This is in contrast to the usually month-long mass administration campaign wherein large number of people are dewormed in a shorter period of time. So we understand that doing a community-based approach, whether fixed strategy or house to house or outreach, will take a longer period of time. And definitely, the guideline also emphasizes that in the course of doing the mass drug administration, observance of minimum public health standards and practicing infection and prevention control measures should be implemented. And this is likewise again implemented or integrated with other public health programs like nutrition or immunization. Let me now show you the trend in the mass drug administration coverage in the Philippines. So you can see here that the trend from January 2016 up to July 22, 2020, and you will see that there were two periods in this graph where coverage was at its lowest points. This was in July 2018 and July 2022. So what happened in 2018 was the consequence of the Dingbaksha controversy, while in July 22 was due to the challenges in the implementation due to the COVID pandemic. You can also see that with much effort to suppress the information due to Dingbaksha, we are almost recovering, as shown by an increasing trend from January 2029 onwards. But suddenly, again, because of the COVID pandemic, there was a decrease in the trend. This slide will also show you the different performance by regions, showing a variable accomplishment. You will observe here that there are different regions who have achieved the threshold of 75% WHO while the rest have 85. And specifically, 10 out of 17 regions have more or less reached the WHO target, while out of the 10, 7 have reached the DOH target. While for the July 2020 accomplishment, sad to say that most of the regions have been performing low, and it's only showing that 8 regions have reached the WH threshold, while 4 out of the 8 regions have reached the national target. So, what have been the innovations that have been conducted to address or improve MDA coverage? You will observe or will see in these slides that there are good practices that are being implemented by the regions. Like there was high coverage among 9 to 15 years old resulted from giving of deworming drops alongside the distribution of school modules during visits of DepEd personnel and school nurses. There was also a house-to-house approach that was being implemented to improve MDA, and some LGUs used innovations to increase their coverage by integrating activities like giving of deworming tablets alongside with the oral polio vaccine, as mentioned a while ago. High coverage can also be attributed to the innovations done by the local government units, such as the distributions of groceries to household after successful drug intake and the conduct of house-to-house administration by barangay officials. There have been also initiatives by some CHD resulting to good MDA coverage, like the conduct of frequent orientation, strong partnership with non-government organization, strong support from local government officials, and information dissemination by radio, and frequent monitoring through frequent calls. Reasons for high accomplishment also includes good coordination with partners, the use of the supervisory coverage tool, frequent update in chat groups, and early delivery of drugs. There is also observed in some regions the giving of incentives and recognition and mobilization funds to best performing DepEd divisions and LGUs. In ARM, it was noted that CHD initiatives include continuous radio plugging of infectious disease programs with the participation of Muslim religious leaders region-wide. So in summary, STH remains a public health concern, and reaching the goal of elimination remains to be seen. The COVID-19 pandemic have brought tremendous challenges in the implementation of MDA services in 2020. These challenges were compounded by the occurrence of various national calamities and disasters, further aggravating existing unresolved issues in the implementation of the program activities in this the stall progress and the control of STH in the country. Despite this, some program implementers have risen to the occasion to resolve these challenges and made some innovations to improve service coverage. So, what is now then the program's next steps and way forward? Well, there are still things to be done. Number one would be doing an assessment and impact evaluation of program interventions, particularly MDA for the Integrated Helmet Control Program, and follow up prevalence studies to update status of states in children and other at risk and vulnerable groups. And lastly, development of policies and guidelines on the conduct of MDA community surveys, surveillance in the context of COVID-19 pandemic. That ends my presentations, and I hope that you have learned something. Maraming salamat po sa inyong lahat.